Now, the next speaker is the former leader of Goodwill Industries for the last 41 years of his 45 years with them. Jim McClellan now serves as the Executive Director for Drug Prevention, Treatment, and Enforcement for the state of Indiana. I gotta tell you, this guy is a frozen chosen. He's a Presbyterian. He belongs to my church, TAB, so I can talk about him. He's a great, fantastic man. So put your hands together for the frozen chosen, Jim McClellan.
Hi, good to see you. Barbara and I go back a long way, probably longer than she would want to acknowledge, but we've been good friends. And I remember when she was at 6. Now, I have to say at the outset here that I think I have the hardest job of anyone in this room today. How in the world do you follow what we just saw and heard? And I tell you, Casey, thank you so much for sharing your story and reminding us why we're here and vividly demonstrating that recovery is possible. And thanks to Isabella, too, for brightening our morning. You know, I want to put this situation in a bit of perspective. There are now more deaths from overdoses than auto accidents and gun homicides combined. In 2016, there were more deaths from overdoses than the total number of Americans who died in the Vietnam War. A small but growing number were toddlers who swallowed pills left within reach in their homes. Overdose deaths in Indiana rose 40% last year. I'm getting a little ahead of myself. They've doubled in the last 3 years, largely because of the presence of fentanyl. Most overdose deaths are from opioids, and you can see on this slide the red line that goes almost straight up. That's the deaths from fentanyl and its analogs. Fentanyl is a synthetic opioid, and it's very inexpensive. It's laced into heroin and increasingly now other addictive substances. It's cheap, it's plentiful, it's very deadly. In Indiana, our opioid prescription rate has come down 25% over the last 4 years, but we still have the 11th highest opioid prescription rate in the nation. Now, that's an improvement from 9th highest about 4 years ago. But I will tell you, friends, there is nothing about this epidemic that troubles me more than the impact on children. And certainly, it's the babies born with NAS, which is rising rapidly across the country, and not all are fortunate to get the kind of help that Casey and Isabella have had. 2/3 of all child maltreatment cases now involve substance use disorder as a contributing factor. The number of kids removed from their homes by DCS because of parental substance abuse rose 22% last year, and these kinds of cases now account for nearly 53% of all removals. A few weeks ago, I was at an event in remembrance of people who had died of an overdose in the previous year, and there were about 40 people who had an opportunity to come up and say something about their loved one who had died, and most of them were parents and some grandparents. And then an 11-year-old boy stood up and talked about how his father had died of a heroin overdose 2 weeks earlier. And I tell you, friends, if we don't do enough to help mitigate the impact on all of these children, I'm afraid that 10, 15 years down the road, we're going to be paying a heavy price. But as Casey reminded us, it's everywhere. It's in cities, suburbs, small towns, rural areas. It cuts across all the socioeconomic lines. And what we would really like for everyone to understand is there are multiple paths to addiction. But once you are addicted, you do have a chronic disease. It has affected the structure of your brain. Fortunately, it's treatable, and few can recover without treatment. But compared with other addictive substances, treatment for an opioid use disorder typically takes longer, and the risk of relapse is higher. So what are we doing about it? Governor Holcomb has made attacking this epidemic one of his top priorities. He decided to do that before he was inaugurated back in January, and it's going to continue to be one of his top priorities going into the second year of his administration. And on the day that he was inaugurated, he signed an executive order that created the position that I'm privileged to hold. And basically my role is to help coordinate and align and focus the relevant resources of all the various state agencies that touch this issue in one way or another, and then to try to leverage the state's resources with those of other sectors, business, higher education, the healthcare sector, philanthropies, faith-based organizations, other community-based organizations. Try to bring the pieces together in a way that's going to give us the greatest chance to have the greatest possible impact. The more you learn about this problem, though, the more you realize how complex it is and how many pieces there are to it. So early on, we developed a strategic approach to attack this. Otherwise, it would be very easy simply to go play whack-a-mole, and that's not going to get us where we need to be. We also realized that we can't do everything at once. There are probably 100 things that we ought to be doing all at the same time. So we had to prioritize. And we also have to recognize that there are no perfect solutions. And we can't let the perfect be the enemy of the good. So some of the priorities are, I think, to me it's obvious, maybe not to everyone. I think one of the top priorities certainly has to be to do everything we can to help keep people alive. That has a lot to do with naloxone distribution and access. Right after that is expanding access to treatment when and where it's needed. We've taken a number of steps to get us closer to that goal, but we still have a ways to go. And along with that, you know, we have to recognize, and we recognized early on, it's far easier to get high than it is to get help, and we have to change that. And along with that, we have to greatly increase supports for people who are in recovery, including more sober housing. We have a serious shortage of sober living accommodations in our state. And then finally, we need to be doing everything that we can to help prevent substance abuse of any kind. Part of that, of course, involves continuing to reduce opioid prescription rates, but we have to do as much as we possibly can to educate and inform people, to make them aware of what's happening and what the risks are of opioid pain relievers. And we have to do everything that we possibly can to prevent the use of addictive substances among young people. Just a few of the items or actions that we've already taken. You may hear more about a number of these from Dr. Walthall later this morning in her presentation, but establishing 5 new opioid treatment programs, and the governor's 2018 agenda calls for increasing that number by up to 10 more, so that nobody is going to be more than an hour's drive away from a treatment center. We have made a policy, yes, that's worthy of applause. We've made a policy change. Again, this is a policy change by FSSA so that Medicaid can now pay for methadone. And let me just say, there are only 3 drugs that have been approved by the FDA for treatment of an opioid use disorder. And they all have their pluses and minuses. Not any one of those works for everyone. And our belief is that we need every available tool in our kit. And so that's now available for people who are on Medicaid. We are also supporting pilot programs that were authorized by legislation passed in the last session, and 2 of those are focused on babies born to moms who were using opioids during their pregnancy. One is the expansion of the Fresh Start Recovery Program operated by Volunteers of America, and there's a session on that this afternoon. The other is a pilot program that we're going to be supporting, a maternal neonatal opioid addiction program that will be operated by Community Health Network. We're establishing mobile crisis intervention teams, putting more peer recovery specialists in emergency departments modeled after what's going on at Project Point at Eskenazi, beginning to use ECHO webinars to train providers, and that's going to help expand the number of doctors who can provide treatment. The contract for that was recently awarded to the IU School of Medicine. Be expanding residential services. Several months ago, we applied to the federal government for a waiver that would enable us to use Medicaid dollars to pay for residential services and recovery support services. We expect that to be approved. We're hoping to get word on that anytime. And we've also launched the integration of Inspect, our prescription drug monitoring program with the electronic health record systems and pharmacy management systems in the state. That's going to provide prescribers and pharmacists with near real-time information to help reduce opioid abuse, diversion, and potential overdoses. And we're working very closely with the Indiana Hospital Association on recommended prescribing practices, pain management protocols, and the Hospital Association and the Indiana State Medical Association are working together to provide continuing education on substance use disorder for all prescribers. And in a great example of leveraging resources, Indiana University has made responding to addictions its third grand challenge, and they've made a $50 million commitment to this effort over the next 5 years. But they're going to launch 15 projects with a combined investment of $13 million in the next 6 months, with additional projects totaling $15 million by next summer. They're going to have a heavy emphasis on projects that have potential for impact in the relatively near future. Regarding prevention, many of you, I'm sure, are aware a 2016 report from the Surgeon General indicated the earlier people try alcohol or drugs, the more likely they are to develop a substance use disorder. Another study showed that 70% of those who try an illicit drug before age 13 develop a substance use disorder in the next 7 years, compared with 27% of those who first try an illicit drug after age 17. The obvious inference here is that we need to do everything that we can to reduce the use of addictive substances by young people. And we can best do that, I think, by expanding the use of evidence-based substance abuse prevention programs and emulating other successful examples. Now, there is an enormous amount of data showing how many of our social problems in this country are interrelated. We saw this in my last career as we focused on finding ways to help reduce intergenerational poverty, but it also applies in our efforts to help prevent substance abuse and to help those who are in recovery maintain recovery. We've got a lot of good pieces out there. But our public sector tends to operate in silos. The not-for-profit sector is very fragmented. A lot of people doing a lot of really good things, but we haven't done a very good job of connecting the pieces, and that's what we have to do. And we strongly encourage the growth and the development of community-based collaborations aimed at prevention, treatment, and recovery, because so much of the work that needs to be done and can be done to help prevent substance abuse and to help those who are in recovery maintain recovery can best be done at a local level. So we need the involvement of community-based organizations and local governments, law enforcement agencies, other first responders, businesses, chambers of commerce, educational institutions, healthcare sector, philanthropies, and faith-based organizations. You know, for instance, there is so much today in our society that tends to divide people. This is an issue we can unite around. It's not partisan. It affects all kinds of people, and we need to come together in order to have the greatest impact in reducing it. I think the best way I've heard it described was from a member of a recovery support group in Winchester, a volunteer, who said to me a few months ago, what we're trying to do is create a safe, supportive, loving community for people who are struggling with addiction. And I don't know how you top that. Higher recovery rates are associated with family and social support and employment. And the more we can do to help strengthen family and community connections, the closer we're going to come to lasting solutions. And regarding employment, part of our challenge now is to link the need that many companies have for workers with the need that people in recovery have for jobs. And I think it would make an enormous difference if more organizations viewed themselves in a larger context, really understanding where they fit in the communities they operate in and how what they do relates to what others around them are doing. Because we're all part of something that's much larger than we are, and none of us can do everything. But if we join forces with other organizations to create networks that leverage complementary resources and capabilities, create synergies, and overcome the limitations of fragmented and siloed approaches, then we can cause some good things to happen that simply aren't going to happen otherwise. That's how we can make the whole greater than the sum of its parts. And to the extent that we're able to do this, we're also going to be helping to build stronger, healthier communities for all of our citizens. When it comes to helping people with substance use disorder achieve and maintain recovery, and when it comes to preventing more people from developing a substance use disorder, there's a quote from Dreamland that I particularly like. You know, nobody can do it on their own, but no drug dealer nor cartel can stand against families, schools, churches, and communities united together. In other words, by bringing the pieces together. Thank you for your interest in this issue. Thank you for what so many of you are doing to help address the problem. And thank you for allowing me to share these thoughts here with you today.